Good morning, class. Today we'll be talking about musculoskeletal disorders. So before we talk about our musculoskeletal disorders, I would like to address the 5 P's of perfusion. This will be pertinent to most all of our musculoskeletal disorders. Pallor, the first P, means the skin is pale or dusky or grayish. Capillary fill is sluggish or not at all. Capillary fill should be 3 seconds or less. Pain is a sign of compartment syndrome, especially unrelieved pain. So we need to address pain, especially any pain that is not relieved by pain medicine. Pulselessness, this is a late sign of poor perfusion issues, obviously, since we don't have a pulse. Paralysis means that the nerves are damaged and the patient can't even move or wiggle their fingers or their toes. Paresthesia, this is a feeling that their limb has gone to sleep, kind of that pin prickly feeling when you wake up and you've slept on your arm or your leg. So that is the 5th P of perfusion. So let's talk about Madison. Madison is a 9-year-old girl who was injured in a bicycle accident. She fell from her bike, resulting in numerous abrasions on her arms, legs, and torso. Additionally, a large laceration is noted on the right arm, and Madison is complaining of severe pain in her right arm. X-rays are completed, which reveals she has a fractured right humerus. The doctor explains to Madison and her family that she will need to have the fracture set and casted. The doctor will also need to suture the laceration. So let's look at these vital signs here. Heart rate is 90, respiratory rate is 20, temp is 37.1, and blood pressure is 100/70. Those are normal findings. So what other assessment data would be pertinent for Madison? In other words, things that you'd be on the lookout for as a nurse. So again, our 5 P's, which we just addressed, and being pulselessness is a late sign, so that's really bad. And we're going to assess pain with our numeric scale, with our 0 to 10 scale, being that she is 9 years old. So what education is necessary to which to provide the family regarding the cast? So we're going to talk about cast education for our family. So let's start out with teaching them about the types of casts, which we have our plaster cast. It is heavy, it's not water resistant, and it takes a long time to dry, 10 to 72 hours. Our fiberglass cast is light, water resistant, and dries quickly in 5 to 20 minutes. Also, when we're talking to the family and to the patient, we're going to let them know that when the cast is being applied, it will temporarily feel warm, but it will not burn. Now, this is different from when days later that they feel a burning sensation, which could be an infection. This is just with the application of the cast, because there is some chemical processes there that will heat up the cast, and they might feel warmth. Teach family to report pain that is not relieved within an hour of pain medication. We just talked about that with the 5 P's. So that means that we have an indicator of compartment syndrome. So we're going to teach family how to perform neurovascular checks and when to report to the healthcare provider. So we're going to kind of go over the 5 P's with them and explain to them what they need to do and when they need to call the doctor. So the next question in your packet, we're talking about the doctor is applying a long arm fiberglass cast to Madison's arm. What are the pros and cons of using a fiberglass cast? And what are the pros and cons of using a plaster cast? So we've kind of just addressed this. Fiberglass cast dries quickly, it's lightweight, it's water resistant. But again, it's not always appropriate according to the type and location of the break. If it's a big break, especially a femur, a big bone, might end up needing a fiberglass cast just to have that extra support. Plaster is more appropriate for long bone fractures that cannot be immobilized by the fiberglass cast. So it fits snugger. It's a little, like I just talked about with the fiberglass, it's not always appropriate for the type of break. A plaster cast might be more appropriate for a long bone. So the cons we kind of just talked about: it dries slowly, 10 to 72 hours. It's heavy. It's not water resistant. So being that it takes so long to dry, it's easy for the family or the patient to put their fingers on the cast, which would result in dents, which could result in skin breakdown or even compartment syndrome. So those are the pros and cons of both the fiberglass and the plaster cast. So Madison has now been casted and she's ready to go home. What would be appropriate discharge orders for Madison? So we're going to go through all these and discuss the rationale for either appropriate orders or inappropriate orders. So the first one, apply ice for the first 24 to 48 hours to decrease swelling. No, we're going to do that for the first 24 hours. Keep the cast elevated above the level of heart during the first 24 to 48 hours. That is correct. Outline any drainage on the outside of the cast with a marker and note the time. Again, that could be because we have a laceration underneath there and it could be bleeding, or it could be infection. So we're making sure that it's not getting worse. Instruct parents to use a warm blow dryer to assist in drying the cast. No, we don't use any kind of blow dryer when drying a cast, and we tell the parents not to do that. We could cause a burn. Inform the parents to contact or call the physician for any severe pain not relieved by analgesics, which we've talked about. Again, that could be that the patient is not responding to the pain medicine because we are developing some compartment syndrome. Teach the parents to assess the patient's fingers and hand every 8 hours for swelling. Again, that is appropriate. Instruct patient to wear the sling when sleeping. So no, we only remove the sling when showering. The sling is to help keep the arm immobilized, so that immobilized and elevated, so that it's just not hanging below her waist and swelling. Administer acetaminophen with codeine, 1 milligram per kilogram every 6 to 8 hours PRN pain. Yes, so that is appropriate as well. And again, if the pain is not relieved with the codeine, we need to what? We need to let the doctor know, because we could have compartment syndrome. So we have progression now of our case study. It's 6 weeks later and Madison comes back for cast removal. Provide the appropriate teaching for Madison and her family. So basically the first thing we're going to do is tell the family and the patient that the cast saw is very loud, because it can be scary and a little bit frightening for the patient, especially when they're not expecting that. So also we teach the parents to soak the patient's arm in warm water and then apply lotion, because that skin underneath there is really dried out. It needs to be soaked in warm water and then lotion applied. So our next patient we're going to talk about today is Jacob. He has been placed in balanced skeletal traction. We're going to talk a little about his situation, and then we will talk about caring for a patient who is under balanced skeletal traction. So Jacob is 10 years old. He was involved in a motor vehicle accident. As a result, he sustained a fracture to his left femur. As a result, he went to the OR and had pins inserted to stabilize the fracture. He comes to your unit from the recovery room. He is now placed on balanced skeletal traction on your floor. His vital signs are as the following. Heart rate is 98, respiratory rate is 20, blood pressure 112/80, temp is 37.5, and weight is 42 kilograms, which are all within normal parameters. So what is our priority nursing care with a patient who is in balanced skeletal traction? We're going to talk about that a little bit in detail if you follow along here on this diagram. So body alignment, we want them straight in the bed. We don't want them scooting down to the end of the bed, because then the weights could possibly touch the floor. So our next nursing care would be pain and muscle spasm management. There's going to be a lot of muscle spasms with this, because we've gone directly through their skin to their muscle, and there's going to be pain, of course, related with that. So again, if we're having pain that's unrelieved, we're worrying about compartment syndrome. So we need to let the doctor know about that. And maybe if we have muscle spasms that are unrelieved, we could get a muscle spasm medicine prescribed to prevent muscle spasms. But again, muscle spasms are just something that is expected. It's not unexpected, but of course we want to keep our patient comfortable. So we want to assess and monitor our neurovascular status, our 5 Ps. We want to maintain skin integrity of the pin sites, and that leads to pin site care. We don't want to see any pain, redness, swelling, drainage, or odor, which could indicate infection. We want to do our pin site care per hospital policy. We're going to have changes in elimination related to immobility. The patient's laying in bed. We can end up with problems with respiratory infections and skin breakdown. We want to make sure we're monitoring those situations, anything that can apply to immobility. Ensure that all hardware is tight and that the bed is in the correct position. We don't ever mess with the hardware or change the hardware, do anything with the weights, but if we see something is not tight or something is wrong, we need to let the doctor know. Assess that the weights hang freely and that the knots in the ropes do not touch the pulley. The pulley is the little wheel in which the rope revolves around, so we need to make sure no knots get caught up in there so that that can move freely. Do not lift or remove weights unless prescribed or supervised by the provider. So we don't touch any of that. If something were to drop to the floor or something were to go wrong, like I just mentioned, we're going to let the doctor know. We're going to do range of motion on the unaffected extremities to avoid contractures. We're going to encourage the patient to use the incentive spirometer and cough and deep breathe, again, to prevent those immobility issues that are associated, can be related to respiratory infections, pneumonia, from being just laying in the bed in one position. Again, that leads to frequent position changes as allowed. Remove sheets from the head of the bed to the foot of the bed. So instead of making the bed from left to right, we'll do it from top to bottom. And we'll do that again like you've done in the past with the bed roll, but we'll only do it from the top down to the bottom. Remove the sheets that way and make the bed that way both. Use the trapeze bar to move in the bed, so that's hanging from the patient's, it's hanging from the actual frame of the bed, so the patient can use that to lift themselves up in the bed if they need to. So the physician has written for Jacob to receive morphine PCA pump 0.1 milligrams every 5 minutes with a lockout of 2.5 milligrams every hour. So is this dose appropriate? So with morphine, I have it up here for you in case you need to calculate this, but it is an okay dose. It's from 0.05 to 0.1 milligrams per kilogram per dose. So that dose is correct. Now Jacob is now complaining that the pain medicine is not working, and you can see that he is having a muscle spasm. What can you do for him about that? So again, ensure proper body alignment. We can get an order for some diazepam or a skeletal muscle relaxant, and spasms should resolve within about a week. So hopefully those will go away and he won't continue to suffer from those. So the next day you come in for your shift, and Jacob says his toes feel funny, like they went to sleep. So we got some issues going on here. You assess him to find the skin is pale in comparison to his unaffected foot, and his nail beds look blue. You ask him to wiggle his toes, but he cannot. So what do you think is wrong? What should you do? Again, this sounds a lot like compartment syndrome. So we do have compartment syndrome going on with Jacob. So what we're going to do, we're going to take action. We're going to assess his pulses, do his 5 P's checks every hour for 24 hours, neurovascular checks. We're going to assess that at least one finger can be placed between the cast and the skin. We're going to notify the healthcare provider. We're going to elevate the leg just to the level of the heart, not above the level of the heart, because we don't want to put such an angle that we cut off even more circulation to that cast, underneath that cast. Loosen any restrictive clothing and prepare for a fasciotomy. So we're going to be preparing for surgery. So we're moving right along right now. We are talking about osteomyelitis, a case study with our patient Cooper. Cooper Smith, age 8, is brought into the emergency department by his parents complaining of right lower leg pain. He is noticeably limping and not bearing weight on the affected limb. The leg is reddened, warm to touch, and swollen, but no drainage is noted. His vital signs are the following. Heart rate is 120, which is elevated. Temperature is 38.4, which is elevated. Respiratory rate is 20, blood pressure is 100/62, and weight is 22 kilograms. So Cooper goes for an x-ray. Based on findings from the x-ray, the doctor highly suspects that Cooper has osteomyelitis and prepares him for a bone biopsy the next day. The doctor also orders blood cultures. Cooper is admitted to your floor. Which nursing actions would be appropriate for Cooper? Select all that apply. Keep patient NPO upon arrival to the floor. No, we're going to make him NPO after midnight. Administer IV antibiotics as ordered. Yes. Ambulate as tolerated. No, we're not going to ambulate. We're going to have him rest. Keep the affected extremity immobilized and elevated overnight. Yes. Place the patient in contact isolation as ordered. So we're not going to put him in isolation. It's not necessary. There's not an open wound and there's nothing draining. Usually with osteomyelitis, you'll just have some warmth around the area and some redness, but no drainage. So Cooper's biopsy confirms that he has osteomyelitis. Which statements confirm that the parents understand the education you have provided, meaning they understand what you've taught them? Select all that apply. Since the infection was caught early, Cooper will need to take oral antibiotics for 10 days. No, he's going to be on IV antibiotics for possibly weeks. Cooper will be able to walk as soon as he begins to feel better. No, he will not walk until the doctor indicates he can. We will need to call the doctor if Cooper complains of dizziness, ringing in the ears, or problems with hearing. Yes, absolutely, because this could be a side effect of his antibiotics. We will provide Cooper a well-balanced diet to help his leg heal. Yes. We will encourage Cooper to watch movies, read, play board games, and play video games while he is not able to get out of bed. Yes, age-appropriate distraction. So moving along, we're talking about club feet now. Case study, Amber. You are caring for Amber Williams, a newborn who has been born with congenital club foot of the left foot. The chart says that she has Talipes virus. The parents are not shocked because this was discovered in utero by an ultrasound. So what are the risk factors involved? So presence of other syndromes, hereditary factors, intrauterine crowding. Also, it can occur with cerebral palsy and spina bifida. So those are our risk factors. So now we're going to talk about treatment for Amber. What is the preferred treatment? So the earlier we can start correcting this, the better, because as she grows, it would only get worse. So we want to correct this as early as we can. So very shortly after birth, we'll do serial casting until maximum correction is obtained. So during that time, we're having those serial casts apply, weekly manipulations of the foot to stretch the muscles and subsequent placement of a new cast. So following casting, a heel cord tenotomy is usually performed, followed by a long leg cast for 3 weeks. And then after that, a Dennis Brown bar that corrects their specialized shoes with a little bar. You see the picture to maintain, correct, and prevent reoccurrence. So this is kind of like if you've had braces on your teeth, this would be kind of like a retainer. So there's a picture of the Dennis Brown bar with the little shoes in the bar between them. So here is just a picture, an illustration of our serial casting. You can see how the patient progresses with each cast until we have correction. So back to Amber, we're going to talk about cast care with the parents. We've already kind of covered that previously, but it's going to be very similar. So we'll tell the parents again that the cast may feel warm when applying, but should not stay warm or get hot later. Keep the area clean, especially these casts when babies have diapers on. They tend to have stool that can leak down out of their diaper. We want to keep everything clean. Do not put in water. We do not submerge this cast in water. It is a plaster cast. Perform neurovascular checks in the hospital every 2 to 4 hours. So while she's at the hospital, we'd be doing neurovascular checks every 2 to 4 hours, and watch the skin and clean the skin as necessary. So again, we're talking about cast care with Amber. Discuss appropriate education on home care for Amber. So which one of these interventions would be correct and incorrect? So appropriate care. It is normal to see some swelling on the toes. That is correct. Apply powder in or around the edges of the cast to keep skin dry. Know that powder will get like goopy and gumpy, and if those are words, and make a whole mess around in there and could cause skin breakdown. So no powder. Do not immerse the cast in water. Provide only sponge baths until the cast is removed. Yes, we do not submerge it in water. Place plastic wrap around the groin area to prevent soiling of the cast. Yes, keep the stool or anything from going down into that cast. Return to the orthopedist's office monthly for cast changes. No, this is the serial casting. They go back sometimes once or twice a week. So this will be weekly and not monthly. So now we're going to talk about leg calf Perth's disease, and our case study patient is David. Let's first talk a little about the patho of leg calf Perth's disease. So what we have going on here is a temporary interruption of blood supply to the femoral head. So what happens is, could have been a trauma, we're not really sure, but anyway, we'll have some necrosis of the femoral head because the blood supply is cut off. So let's talk about David. He's 8 years old, brought to the pediatrician's office with a sudden onset of complaints that his left leg is hurting. You notice he is limping, his hip is stiff when he walks, and he has limited range of motion in the affected leg. An x-ray confirms that he has leg calf Perth's disease. So what risk factors do we have here? So ages 2 to 12 years, with the most common age being 4 to 8 years, males, and then a risk factor, we might look back on the history and see that he had some sort of trauma inflammation to the femoral head. So what are some other clinical manifestations, any objective and subjective data that we might see with David. We might notice that he has an intermittent painless limp, his hip is stiff, limited range of motion, hip, thigh, and knee pain because the pain is radiating because of what's going on and with that inflammation, shortening of the affected leg, and muscle wasting, again, because we're just not using that leg. He's not applying any pressure to that leg. So the doctor recommends that we hospitalize David and for treatment. So what interventions will be appropriate for his care? Select all that apply. So encourage him to ambulate freely when he feels better. No, we're not going to have him ambulate because we do not want him to put pressure on that joint or on that femoral head, because when he stands up, he'll put pressure on that and again cut off the blood flow. So no, he needs crutches with limited weight bearing. Complete neurovascular checks every 2 to 4 hours. That's correct. Obtain a referral for physical therapy. That is correct. We want to strengthen up those muscle wasting that we have going on with that affected leg. Administer opioid medications as given. No, we're going to give NSAIDs because we have an inflammatory process going on here. Maintain skeletal traction and provide pen site care for hospital policy. Yes, we might see pen site care being used, and if you notice that as being one of our treatments, and is in your ATI book, but it's not the typical treatment that we do. Limited weight bearing is our #1 treatment for leg calf Perth disease, but I just wanted to mention to maintain the skeletal traction and provide pen site care for hospital policy, just in case you see that somewhere in your book. So the doctor recommends that David have surgery. Which statements indicate his parents have appropriate understanding, meaning they understand what you're telling them about the teaching with David? Select all that apply. Ibuprofen will be given to David to help reduce swelling. Yes. He will be able to walk immediately after surgery. No. Again, limited weight bearing and will be using crutches. We will need to bring schoolwork for David to complete while in the hospital. Yes. We can apply ice or heat to help relieve pain. Yes. Physical therapy will help David with using his crutches. Yes. Again, we'll be with limited weight bearing until we have complete healing of the affected joint. So now we're talking about Lillian. Lillian has developmental dysplasia of the hip. So I have an illustration here for you where you can see a normal right hip and the deformed femur head, where you can see that it is out of place. It's not even connecting with the socket there. So Lillian Harris is a 2-day-old neonate who has been diagnosed with developmental dysplasia of the hip, her right hip. Lillian has no other problems noted. Her birth weight was 7 pounds 14 ounces and she is 20 inches long. What are risk factors for this condition? So I've listed them here. Firstborn, female, family history, breech delivery, delivery type, whether it be a C-section or a vaginal delivery, joint stability, oligohydramnios, and large for gestational age. So those are all risk factors. So the nurse completes an assessment on Lillian. Which of the following findings would validate this diagnosis? So lengthening of the affected leg? No. So the femur is shorter on the affected side. Positive Ortolani test? So yes, that would be the hip is reduced by abduction. So by adding, the hip is reduced, in other words, it goes back into the joint by abduction. Negative Barlow test, no, this should be positive as well. So the hip is dislocated by adduction. Positive Trendelenburg test, no, that's only in older kids, especially because we have to assess that when the patient is walking. Asymmetry of gluteal and thigh folds, yes. Limited hip abduction, yes. So you explained to Lillian's parents that treatment of DDH starts as soon as it is diagnosed and dependent upon to the extent of the dysplasia. Discuss each treatment below. So Pavlik harness, so it's a chest harness that abducts the legs. The patient's going to wear it for 10 to 12 weeks. The straps will be checked and adjusted every 1 to 2 weeks by your physician. Perform neuro and skin checks. So I'm going to show you a picture on the next slide that it shows the straps. The straps can break the skin down if we don't have appropriate clothing underneath, and also if they're too tight, we can have some neurovascular issues. Removing harness is dependent upon the client. We rarely let the patient do that, the family do that rather, because we don't want to mess up the adjustments on the strap. So we might see how much the parent understands about putting the straps back on correctly. We can assess that. Bryant skin traction, again, this might be used rarely, but Pavlik harness is usually our treatment of choice, but I just mentioned that we use the skin traction with the hips flexed at a 90-degree angle with buttocks off the bed. So here's a picture, a good illustration of a Pavlik harness. You can see the child has got socks which cover the lower straps, the leg straps. We have abduction strap, shoulder strap, and chest strap, and we always have some clothing underneath those straps to make sure that no skin breakdown takes place. So the doctor decides to treat Lillian with the Pavlik harness. Provide education to include harness care, skin care, transporting a child in a harness, and length of treatment. Again, we discussed a little bit of this just earlier. The baby will be wearing the Pavlik harness for 10 to 12 weeks. The straps will be adjusted every 1 to 2 weeks. We're going to be doing neuro and skin checks. Removal of the straps is dependent on the client. And again, family, we do not have the family adjust straps. We can teach the removal of the straps if prescribed, to wash them and clean them, especially if it's a parent that might live far away and can't come in as often as they need to. Maybe if the straps get dirty and they need to have them changed, we might teach these families how to wash and reuse the straps, but we don't have them adjust them. Again, we do not use any kind of lotions or powders under the straps because that can, again, cause some skin breakdown. It can cause that to get all thick and yucky up under the straps. So we don't do any powders or lotion underneath the straps, and we place the diaper underneath the straps. In other words, you never have the straps underneath in the diaper, because again, you could get the straps could be soiled with urine or stool. So we always make sure we have the strap underneath the diaper underneath the straps. So as we progress with Lillian, she has worn her harness for 12 weeks now, and it has been determined that her hip dysplasia has not improved. The orthopedic surgeon decides to place Lillian in a hip spica cast. What are the nursing actions for a child in a hip spica cast? So again, we're talking about cast care. We'll talk about that a lot as we continue with musculoskeletal disorders. But it's going to be very similar. So anytime you're thinking of a cast, we're going to be worried about perfusion and compartment syndrome. So let's look at these selections down here and we'll pick the right answers. Line the diaper with plastic to prevent soiling of the cast. Yes, we don't want any stool or urine to get down into the cast and cause infection. Perform neuro checks every 6 hours. No, while she's in the hospital, we'll be performing those every 2 hours. Assess pain every 4 hours in PRN using appropriate scale. So no, again, immediately after surgery, we would be assessing every 2 hours. And what scale will we use? We'd use our FLAC scale. Monitor intake and output frequently. We want to make sure that after surgery, the patient is recovering and hydrated. Do not move the unaffected extremities. We will do range of motion, so we do move the unaffected extremities. Assess perineal area for skin breakdown or redness. Yes, we want to make sure we don't have any diaper rash going on, any skin breakdown. So now we're going to be sending Lillian home with her family, and we're going to talk about education for her parents. So we're going to reinforce teaching regarding positioning, turning, neuro checks, and care of the cast, things that we've just talked about previously. We can position the cast on pillows for comfort, especially as we're drying, because it does take those a while to dry. So if she's been in the hospital overnight even, they might not be dry even when she gets home. Keep casts elevated until they dry. Like I just said, with pillows, we can position with pillows. Encourage frequent position changes to allow drying. Yes, we're going to make sure all areas of the cast get dry, because all areas of the cast need to be exposed to air in order to dry. Handle casts with the palms of your hand until dry. Again, we don't want to make any kind of dents in that plaster where we could end up with some skin breakdown or compartment syndrome. Note color and temp of toes on the affected extremity. Yes, we would note the color and temp, and again compare them to the unaffected extremity. Give sponge baths to avoid getting the cast wet. Yes, we wouldn't want the cast to get wet, especially with a plaster of Paris cast. It takes it a long time to get dry. Use a waterproof barrier around the genital openings. Yes, because we don't want any stool or urine to get down into the cast. So next we're going to talk about osteogenesis imperfecta. I'll refer to it as OI, the abbreviation. So it's a connective tissue condition that results in bone fractures and deformity along with restricted growth. So I have a little illustration here that can show a normal healthy bone versus the brittle bone. And you can see how spread out the bone is, the periosteum and the spongy bone. It's very spread apart. It's not solid like it should be. So now we're going to talk about risk factors of OI. So our one and only risk factor, it's genetic. It's having a parent with OI. So which of the following are assessment findings of OI? Select all that apply. So visual deficits, no. Multiple bone fractures, absolutely, that is our number one assessment finding. Blue sclera, yes, again, that is connective tissue. It is collagen, so it will have a blue tint to it. Curvature of the spine, not usually with OI. Small discolored teeth, yes, because they are bones, so they are small and discolored. And hearing loss because of the conductivity issues with the small bones in the ear. And also, how is OI diagnosed? So the only way to diagnose it is a bone biopsy. We're looking at the bone mineralization, which will show the abnormal bone structure and fractures. You saw the abnormal bone structure on the first slide, so you can refer back to that to see the abnormal bone structure. So what is the primary medication used to treat OI? List adverse effects. So we only have one medication. It's supportive, it's not curative, and it's even in experimental stages. It's called pimidronate. Unfortunately, it has a lot of bad side effects. The number one, bone pain, nausea, and vomiting and dizziness. Also adverse effects, we have all kinds of things going on with our electrolytes here. Hypokalemia, hypomagnesia, hypocalcemia, hypophosphatemia, thrombocytopenia, neutropenia, dysrhythmias, kidney failure, and general malaise. So the side effects sound almost as bad as the disease in this case. So with kids with OI, we need to prevent traumatic injury. So let's talk about a few ways we can do that. Low impact exercise to prevent fractures. Low impact exercise, a perfect one is swimming. Use of braces and splints to support bones and joints and prevent fractures. It used to be they'd put casts every time the child would break the bone, also to prevent further breakage, but we figured out braces and splints were better to just support the limbs. Physical therapy, we work closely with physical therapy to maintain any kind of muscle strength we can. Handle with care, we want to make sure that, that especially with babies with severe cases, a fall could be completely devastating. Educate parent on limitations. So of course we're going to educate the parent that this child is not going to play football or basketball, hockey, any kind of contact sport, that the child will have limitations when it comes to physical activity, and they need to understand that. And like I said before, swimming is a perfect exercise for these children. So we are moving along talking about our case study, Darla, who is a patient with scoliosis. You can see an illustration there of the scoliosis, how it affects your whole, even your internal organs, the way your spine shifts, your rib cage to the side will have some abnormal curvature of the spine, the ribs, pelvis, and even, like I said, the organs can be displaced when it's as curved as this illustrations is. So we're going to talk about Darla. She's 15 years old. She's a sophomore in high school. She plays basketball and softball. She presents to her pediatrician's office for her routine annual physical. One aspect of her physical is a check for scoliosis. So during the exam, the doctor notes that her spine is curved and one shoulder is higher than the other. The curvature is measured at 30%. So screening takes place for both during pre-adolescence for boys and girls. So we're going to observe the child only in their underwear from the back, bend over with the arms dangling at the waist, so we can see the emphasized bones of the spine to see if there's any curvature. So what are other assessment findings that may be indicative of scoliosis? So I kind of mentioned these earlier. Asymmetry of the scapula, ribs, flanks, shoulders, and hips. Also, clothing will appear improper fitting. One leg is shorter than the other just because of the way the body is tilted. So you'll see clothing that doesn't fit correctly. That's one of the things that you can notice before you even examine the patient. So with the 30% curvature, what would the doctor tell Darla regarding treatment? So we're going to talk about following her care and how we're going to do that. So let's go through this list and pick the correct answer. She will go to PT weekly for an exercise regimen to help straighten her spine. No, that would not help. We're not going to straighten the spine with PT. She will go to surgery tomorrow. No. She will be referred to an orthopedic surgeon for a decision about treatment. Yes, she will need further follow-up to make sure that this curvature is not progressing. Last answer, which is incorrect, she will be given a back brace to wear every other day that will correct the curvature in her spine. So a back brace, that's wrong in two parts because it's not going to correct the curvature, and when she has to wear it, it would have to be 23 hours a day every day, so only to take off to shower. So if she were to wear a brace, it would be on 23 hours a day. So 2 years after wearing her brace, Darla's curvature has progressed to 46%. She will be admitted to the hospital for a spinal fusion with Harrington rod placement. You will need to provide pre-op education to Darla and also what to expect post-op. So pre-op, we're going to do a lot of teaching with her, what to expect once she gets back from surgery. So we're going to teach her about the incentive spirometer, how to use it, what it's used for, coughing and deep breathing, teach her about her PCA pump, how she can get pain medicine, tell her about log rolling. That's how we're going to move her in bed, which means we put her arms straight and legs straight down to the sides and move as a whole unit. So move her like a log. Respiratory therapy techniques used to help prevent any kind of pneumonia, any kind of issues with immobility. Discuss any unfamiliar medical terms. Education promotes compliance. That's the number one thing we need to worry about here, is making sure she and the family understand what we need to do after the surgery to be compliant with treatment. So post-op, emphasize importance of PT. There's where our compliance comes in. Encourage independence with ADLs. Encourage friends, peers to visit. Emphasize the importance of follow-up care. Again, with compliance, especially with our physical therapy. So we've talked about the family with pre and post-op. Now we're going to talk about you as a nurse. What are your priority nursing interventions, both pre and post-op? So pre-op, we're going to prepare for autologous blood donation. That means she will donate some of her own blood. We're going to do labs. Even we'll do a type and cross in case she might need to have other blood other than hers. Maybe she used up her own blood, her own donation. Orient the patient and family to the ICU, because the ICU is kind of a scary place. There's lots of noises, lots of commotion, lots of things going on. We need to make sure the family knows that there's nothing wrong, and with seeing a lot of commotion in the ICU, because that's normal. Inform the patient and family about a possible NG tube, chest tube, Foley catheter, and PCA pump, because it is quite shocking to a family to come back and see their child with all these things hooked up to them, with all these different tubes coming out. So we're going to prepare them for that. Post-op, we're going to go post-op care, pain scale. We're going to talk about the PCA pump with the family, about usually the patient is the one that uses the PCA pump unless we have a family-assisted analgesia, but usually if she's old enough, she can use her pain pump when she needs to. We're going to perform our neurovascular checks. We're going to log roll, assess skin, especially if a brace has been ordered. Make sure that the skin that she's on her back is not broken down from that brace that she'd been wearing. So keep skin clean and dry. Monitor surgical site, of course, and drains if we have any for signs and symptoms of infection. Assess bowel sounds. With all of the anesthesia, she could have had an epidural anesthesia as well with her surgery, so we could end up with some bowel blockage, even a paralytic ileus. Monitor our H&H for bleeding. We're going to administer blood as indicated per hospital policy. Encourage ambulation ASAP. range of motion, age-appropriate activities, encourage family and friends to visit, because yeah, she's a teenager, she's going to want to see her friends, so make sure that we encourage family and friends to visit. So we are moving right along. We're getting ready to talk about juvenile idiopathic arthritis, or you might have heard juvenile rheumatic arthritis, but we're talking about idiopathic, meaning we don't necessarily what caused the arthritis. So case study, we have Marie Wilson, age 10, is brought into her pediatrician's office by her parents. She presents with bilateral elbow pain and swelling along with swollen and painful right knee. She has no history of recent injury or trauma. Her joints appear reddened, stiff, and she has a low-grade fever. She is noticeably limping on her right leg. Her x-ray confirms inflammation and elevated ESR and WBC. After many weeks of diagnostic procedures, Marie is diagnosed with JIA. So symptoms must be there for 3 months. So for a while we're ruling out other things, but all these symptoms have to be positive for at least 3 months. So list 10 interventions you can recommend that will promote a higher quality of life for Marie. So again, this isn't a disease that is cured, but we can promote a better quality of life. That is key here. So exercising will help with the stiff joints, relaxation techniques, especially during any kind of exacerbations of pain, relaxation techniques, guided imagery, things like that, things you've learned about in the past, non-pharmacological pain relief. Evaluate response to analgesics. Often if we're not relieving pain, if the analgesics are not working, then we need to try something else. Support group is really important because this is a debilitating illness and affects mobility, so other kids can be really cruel. So we want to provide support groups not only for the family but for the child. The child will need support throughout their life. So patient is to increase mobility and prevent deformities. PT, rather, we use PT to help with mobility, to help the contractures, deformities. Activity is tolerated, so any kind of activity that is good for her would be especially kind of like warming up exercises in the morning, swimming, things. Activity is tolerated, but not to push yourself, especially during times of exacerbations. Full range of motion, so we'd be doing range of motion, keep all of those joints movable and limber. Warm moist packs to joints before exercise, so to warm those joints up before exercising. Warm bath, especially in the morning if she gets up and feels stiff and needs to go somewhere that day, do a warm bath first thing in the morning. So I identify alternative ways to meet developmental needs during exacerbations. So if we're having an exacerbation, we might have a school teacher come in, maybe do some online classes like y'all are doing now. Do some learning at home if we can. Self-care, we're going to teach her about self-care, not only for her body but for her mind. So take care of herself. This can be a very depressive type thing, so make sure that the patient is has good self-care habits. Good diet with increased fluid intake. School and peers, it is important that she gets to school to socialize and have peers, especially when I mentioned earlier support groups. Maybe she's made some friends from support groups. So collaborate with school nurse and teachers for meds and school part-time split days, extra set of books. So if she needs meds at school, we'll have to get all that together and help with that at school, get that to the school nurse, directions on her meds. So the part-time split days, maybe she's having an exacerbation, but she's getting a little better, so she could go to school a half a day. Maybe she would take her academic subjects in the morning one day, and then in the evening, the afternoon, the next day, kind of alternate so that she gets to at least come to school part of the day. So exacerbations worsen with illness. So again, we're going to make sure she's getting her immunizations and her flu shots, make sure she's not around sick people, avoid sick people, especially if she's had an exacerbation, had to be on steroids, so avoid crowds, and then also have regular eye exams because one complication is uveitis, so we're getting regular eye exams. So the doctor has prescribed ibuprofen for inflammation and pain. What would be appropriate when teaching Marie, her family, about taking an NSAID? So what do we all know about NSAIDs? Of course, they can cause bleeding. So let's go through this list. And of course, I just told you the answer, but take medication 1 to 2 hours before meals. So we're going to make sure, no, she's going to take the medication right at the time of the meal. Slight weight gain is expected. No, not with NSAIDs. We're thinking more along the lines of steroids there. Notify the doctor immediately of stomach pain, changes in stool, or bruising. Again, that's because we could have some bleeding issues with long-term NSAID use. Take the medication only as needed for pain. No, she will have these medications on a schedule, so we're not going to take them PRN, we're going to take them as scheduled. So just a while ago I mentioned that the patient might be on corticosteroids at times. So why do you think, though, initially the doctor did not prescribe corticosteroids to Marie versus an NSAID? Well, once we start on corticosteroids, we can develop a tolerance for them. So we're reserving those steroids for our life-threatening complications listed here. Severe arthritis, so severe exacerbations of her arthritis, pericarditis, and uveitis. So we're going to start with the NSAIDs, and we will save those big guns, as we call them, the steroids, for more serious illnesses. So Marie's condition has continued to gradually worsen over the last 5 years, and the doctor decides to place her on methotrexate to slow the progression of rheumatoid arthritis. What client education is appropriate for Marie and her family? Select all that apply. So appropriate education. So drinking alcohol is to be avoided. That's correct. We do not mix methotrexate and alcohol. Weight gain, especially in the face, is a common side effect. No, not of methotrexate, but that's more along the lines with steroids. It will be necessary to take an effective form of birth control to avoid birth defects. Yes. So we don't know if she's sexually active, but we still provide that. We provide that information. Blood glucose levels will need to be taken daily at home. No, that's more along the lines with our steroids. Liver function tests and CBC will need to be completed regularly. Yes, we want to also monitor our CBC and our renal clearance. So liver function test, CBC, along with a renal clearance test. So next we're going to be talking about muscular dystrophy, and we'll be talking about the most common form of muscular dystrophy and what is the risk factor for developing this condition. So our most common form is Duchenne's muscular dystrophy, and it is a X-linked recessive trait. So I've provided you a diagram here of an X-linked recessive inheritance. Mother is a carrier of the condition. So you can see by looking at that that little chart there that how many children will end up with the actual disease and who will be carriers. So which of the following assessment findings would validate a diagnosis of muscular dystrophy? So we're looking at signs that would validate the diagnosis. So let's go through these. So fatigue, yes. Learning difficulties, yes. Frequent falls, yes, from the muscle weakness. Enlarged cervical lymph nodes, no, it's not an infectious process. Muscle weakness beginning in the lower extremities, yes, mainly in those pelvic girdle muscles that will help, that work in conjunction with the big muscles in your legs. So the first thing you might see with these kids as they get a little older, difficulty riding a bicycle. The legs can't turn and the pelvis can't support that. Frequent headaches, no, there's not associated with muscular dystrophy as a definitive diagnosis. Unsteady waddling gait, yes, you'll see that because again those pelvic girdle muscles are weak. Upward slant to the eyes, no, that's more with our Down syndrome patients. So which of the following tests would be ordered to confirm diagnosis? So an EEG, no, that's brainwave test, we're not looking at that. Serum creatinine kinase, so that's indicative of muscle breakdown. So that would be one of our tests to confirm. Bone biopsy, no, not affecting our bones. This is more our muscles. Complete blood count, nothing that would be definitive on a complete blood count. EMG, now that is the stimulation of your muscles, so that would be one that would be a diagnosis. Muscle biopsy, yes. ESR, again, this isn't an inflammatory process, so we wouldn't need to look at the ESR. Bone scan, no, it's muscular, not bone. Serum polymerase chain reaction, yes, because that would be indicative of our genetic mutation, and possibly with that we would need to do some education with the family. So what priority nursing goals for a child with muscular dystrophy and interventions would help you meet these goals list below? So genetic counseling, that's parent education, again going back to see if mom's a carrier, obviously, so we need to talk about future children. Assess and monitor ability to perform ADLs, respiratory function, cardiac function, parent and child understanding long-term effects. So we want to make sure the child can perform their ADLs as long as they can, because you know, the independence is important and makes them feel like they're you know, like a normal developing child. Coping support system, we need coping and support system for both the family and the child, and again, because this illness is progressive, so the child is going to continue to get worse. Maintain optimal functioning as long as possible, independence with ADLs, range of motion, activity, stretching, strengthening, muscle training, and breathing exercises. So helping with all those, bringing in physical therapy to help us with that. Body alignment, reposition to avoid skin breakdown. As the child's disease progresses, they'll become more mobile and they'll be in the bed a lot more. We need to prevent skin breakdown. Respiratory functioning, so incentive spirometer, repositioning, mechanical cough device, O2, non-invasive ventilation like a CPAP. So they might need some extra pressure to help them breathe, because they're, again, the muscles in their diaphragm are failing, so they cannot breathe on their own. It'll get more difficult. Also, even with coughing and clearing their secretions will become more difficult. So we'll need that mechanical cough device, which provides a little pressure and helps them cough. Increased fluid intake, nutritional intake, physical exams, and immunization. So all of those, especially immunizations, because as the disease develops and progresses, the patient will be on steroids, so the patient will need to keep up with immunizations and limit sick contacts especially. Facilitate end-of-life decisions. Again, like I said before, this is a progressive disease. The child is not going to improve. The child is only going to get worse as the years go by. So providing family, you know, with and patient with end-of-life decision making. So prednisone is commonly given to increase muscle strength in patients who have muscular dystrophy. What will you need to teach the family about prednisone? So we've talked about this earlier, but we're going to select all that apply. We're going to talk about prednisone. So the child will need to avoid crowded locations, especially during cold and flu season. Yes, because prednisone affects our immune system, so we need to make sure we limit sick contacts in crowds. Teach the family the signs and symptoms of hyperglycemia. Yes, because definitely with hyperglycemia with steroids, we need to teach them the signs and symptoms, and we might even have to start taking blood sugars. The child may lose weight while taking this medication. No, they're not going to lose weight. They're going to likely gain weight. Teach the child and family healthy eating habits. Yes, because steroids tend to increase the appetite and will even cause the patient to crave sweets. So we need to talk about healthy eating habits. Instruct the family not to worry if the child has dark stools, as this is a normal side effect and will pass. So no, absolutely not. That could indicate GI bleeding, so we want to notify the healthcare provider anytime we have any signs of bleeding. So this conducts our lecture on musculoskeletal for today. I do, after this slide, have a short video for you to watch in progression of muscular dystrophy, because it really illustrates well the progression of the disease and will probably help you with picturing this in your mind for when you're taking your test. So please watch this short video here at the end, and I'll talk to you on Monday about genitourinary and neurological disorders. So have a great weekend.